There's really been, I think, a lot of excitement that we are on the cusp of developing new therapies that are really going to help patients. You probably know that in other kinds of leukemia, such as CML and now CLL, there's been a lot of progress with small molecule inhibitors of molecular targets. And I think the feeling is in AML that we're on the cusp of that with molecularly targeted therapies and also with antibody-based therapies, which have really come into their own. And there are a number of presentations at this year's meeting, I think, that demonstrate that antibody-based therapies may be another strategy to help patients with this disease. It's been known for about 5 to 10 years that there are various recurrent somatic alterations in patients with acute myeloid leukemia that are important for disease development. And as the years go on, we're discovering more and more targets that we can potentially hit to treat patients with AML. So the reason this is important is that with the revolution in sort of our understanding of the genetic underpinnings of AML, we've really been able to now develop unique small molecule targeted therapies that go after either mutated proteins or go after proteins that may not be mutated but may be overactive in the treatment of AML. Some of those, and the ones that are in sort of the farthest stages of development, are inhibitors of mutant FLT3 and inhibitors of IDH, isocitrate dehydrogenase. If you've got a randomized phase 3 study that is positive and shows an overall survival benefit, that may be practice changing, and it may really change what we do for those patients with that specific genetic abnormality. There are some other drugs in development that are a little bit further behind. There are a number of randomized phase 3 studies for other FLT3 inhibitors. There's now a randomized phase 3 study for patients with an IDH2 mutation. So I really think that for the first time, we're seeing a number of targets that we're going to be able to go after that are relevant and may yield spectacular results. So that's the big question. So what do we do? Do we use these drugs as single agents in patients with newly diagnosed AML? Do we use them in combination? How does this all go down? So I would argue in patients who have newly diagnosed AML who are fit enough to receive chemotherapy, what we will likely end up doing is adding these novel targeted agents to standard chemotherapy or standard hypomethylating agents. And the reason for that is because AML is not a disease with one mutation, it's a disease that has multiple mutations. So even if you hit that one mutation, you probably have a host of others that are going to cause problems and cause the disease to progress. So in order to really capture everything, you might need something a little bit more nonspecific like chemotherapy, in addition with a targeted agent that hits the specific, difficult to eradicate abnormality of interest. The other thing that I think that we may be doing, especially in older patients who may not be candidates for chemotherapy, is using these novel agents in combination. So you can imagine if you had an inhibitor of molecular genetic abnormality X and molecular genetic abnormality Y and molecular genetic abnormality Z, and somehow you could combine them all together and you can give it to the patient so that you can tailor the therapy to the specific genetic abnormalities in that patient's leukemia. That is also a possible way that we can think about moving forward to treat this disease. On the advocacy side, ASH is crucially important for getting the funding for helping lobby for the funding that's needed from the federal government to push the research forward so these genetic discoveries can be made and so that inhibitors of these targets can be discovered and brought into the clinic. So that's another crucial part of it. Without the money, there's no research, and without the research, there are no cures. It is crucial for every hematologist, really all over the world, to do their best to support ASH in whatever way may be possible, whether that's financial, whether that's by volunteering time, whether that's by getting involved in committees, whether that's by attending meetings, not only in the United States, but also around the world where ASH sponsors joint symposia. I think all of those things really push the field forward, and I can't say how important it is to have that get done.